Good afternoon, everyone. My name is Pradeep Kaul. It is a pleasure to be here today. I used to live in Nashville many years ago as part of a company called Ph.D, which became MD, which became Change. It's been a while, but 15 years later, it's good to be back. Let me introduce myself a little bit. I've spent my entire career in healthcare on the administrative side, first working as an independent vendor to the Blues, then working for the Blues, and then working a lot in the government on the implementation of health savings accounts, followed by accountable care organizations. The journey has been a professional and a personal one. I am the proud builder of many of the siloed systems: eligibility, enrollment, care management, member management, adjudication, payments, and all the buzzwords. But a few years ago, when my son was born with a number of cognitive and learning disabilities, I realized with all the incredible horsepower that we own in our data centers, we really do nothing to engage the patient or the family that needs care. And that process of getting care remains untenably and unacceptably complex. And that's despite having all the major healthcare executives on speed dial. So caused me to stop, get off the corporate perch, and start Solve.Care with a true objective of addressing some of these barriers to care that we all talk about incessantly, but yet struggle to overcome. That's the vision and the mission of Solve.Care. We happen to use a technology called blockchain. You've heard a lot about it as a decentralized ledger underneath the platform. But at the end of the day, that is just an enabling technology. I think what we're really looking at is a new approach and a new way of administering healthcare. I won't bore you with blockchain, but fundamentally what it does give you as a technology is a decentralized ledger or replicated ledger that you can have a copy of in your hands, either entire ledger or part of it, and that gives you the ability to stay connected with the events that surround your care. And this ledger is immutable in the sense that modifying it accidentally or intentionally is not possible, and anybody can verify the ledger to be accurate. Those key properties allow us to rethink the patient-provider care relationship, which most of us have played multiple roles. I've played all three roles of a patient, provider, and payer. So what we're looking to do is to deploy this ledger technology inside a healthcare operating system that enables more effective peer-to-peer transactions and decentralizes functions that don't need to be centralized, that are overly centralized into clearinghouse functions, but we had no other mechanism, be it eligibility verification, be it referrals and pre-authorizations, or even adjudication and payments. What I'm going to talk to you about the next 12 minutes is a system we have put in production with a client, Arizona Care Network, which is an accountable care organization, as the name implies, in Phoenix, Arizona. They are currently using the system to pay their providers for value-based contracts. So much of what I'm going to share with you is either in production or in deployment with them. So let me jump right into it. So from an insurance perspective, who are their clients? ACOs, by definition, work on behalf of payers to provide more effective care coordination and outcome management for a group of members or population groups that they're responsible for. Those population groups can be centered around disease, around the demographics, around geography, but at the end of the day, you are trying to manage the care of a group of people more effectively. And the more you can engage them, the better results you're going to have. So there's an alignment between the interest of an ACO and a patient, and that's where these use cases become very interesting. So what we have done is we've launched a platform that is being used by ACN with all their providers in the network, which comprises about 1,100 primary care physicians and 4,500 or 4,000 or so specialty care and hundreds of facilities. And the objective here is to give the patient provider a decentralized peer-to-peer capability without requiring the patient to have a mainframe in the living room, which last I checked, none of us do. So it really is about decentralized delegated authority. And the use cases we are implementing there, starting with value-based payments for performance contracts, and then leading to demand-based scheduling, consent management, benefit explanation, eligibility verification, and so on. The second set of use cases that are in production or in deployment are around patient giving consent for treatment, for HIPAA, for billing, for record sharing, for organ donation, and so on and so forth, which allows third parties to reuse that consent and or to delegate that consent in the event that the patient so desires. There are also use cases around group and individual enrollment, which are in flight, and there are several other patient pair use cases as well as employer pair use cases. We're launching a platform use case, again in Arizona, around prenatal care for women at risk during pregnancy because of genetic or age or previous issues with pregnancy, and in ensuring that they have timely and complete access to preventative care, and they have proper nutritional support as well as they have proper postpartum care, including mental health support to deal with things like postpartum depression. How does it work? So the notion here is that using the blockchain, we create patient-centric networks. So the sponsor of the network is the payer, the Medicaid agency, or an ACO, and they allow each patient to register on the blockchain as a node. Once the patient has registered on the node, we can link that patient to other nodes for very effective and need-based coordination. So the objective here is that while I may have 1,100 primary care physicians on my network, there's only 2 that you are going to work with, a pediatric and a PCP in most cases. So your network isn't 1,100 paid providers. Your network is 2 providers, 3 specialists, and possibly a lab and a pharmacy. The idea is to allow a patient-centered network to be created around that patient's need episode, chronic or otherwise. Once you have that network, all the parties in the network can exchange information based on the consents that I've given them. And that consent is immutably recorded on the chain, so I can make sure that my consent is not abused, and ultimately I can revoke it. You know, as a rhetorical point, how many of you have ever gone into a physician's office, given a HIPAA consent, and 1 year later gone back and revoked it? I know I haven't. I don't think any of you have either by the raise of hands. That's not the intention of the consent. It is not meant to be a blanket consent in perpetuity. It is meant to be episodic. It's meant to be around a specific care need. And those consent management is a key part of reducing liability on both sides, patient and provider. The way the system works, it's a complete healthcare operating system in effect. It consists of a care wallet, which is in the hands of every stakeholder. The wallet recognizes your role on the chain. So if I'm a patient versus a provider, my wallet will contain different care cards. Those care cards are decentralized apps that live in my wallet because they're specific to my role on the chain, or specific to my disease, or the programs I'm participating in, or benefits somebody's sponsoring for me. So if I am either a pre-chronic or a multi-chronic member, as a previous CIO for Blue Cross, I want to get you certain treatments, certain cards, certain pre-authorized care that I want to make it easy for you to take, because that's the only way I'm going to bend the cost curve. So in my wallet then will appear the cards that are sponsored by my payer that allow me to do certain things with my provider without needing the payer to participate in that process. So cards and wallets and cards allow me to have a very personalized experience around access to care, around disease management, and around payments of care in the form of copay, co-insurance. And these cards can be dynamically calculated with fundamentally a smart contract on the chain. So if I do certain things, my next visit to the physician may have 0 copay. That would only happen because I did certain things, and those things are registered on the chain as an event that lead to a better outcome for me and a lower cost for the payer. We also allow our client network sponsor to issue coins, which are essentially digital payment tokens that are changeable and exchangeable between wallets. So if I get care points from my employer for being for complying with the wellness program, or because I am generally a healthy individual complying with all the best guidelines, so they're giving me certain points, I can use those coins to make co-pay payments, or I can use those coins to buy additional services, as long as that payment is done within the network. So it's an intra-network payment model. All of this capability sits on top of a care protocol, which allows us to bind any 2 parties into a defined relationship: patient-payer, patient-provider, payer-provider, and so on, patient-employee, or rather employee-employer, employer-broker, and so on. There really isn't any definition of healthcare transaction that we cannot bind into a predefined protocol, which then is inherited by all the cards and wallets above it. So with that technological background, I want to show you some of the actual use cases that are in production in Arizona. I'm going to skip past the animation. Here is an example of a demand-based scheduling where I, as a patient, can actually can receive from the physician their availability in the form of a care card. I can put out a request on the chain, requesting an appointment for my son, which means every pediatric in the area that has availability at 9 a.m. on Tuesday can respond to it, not different than Uber, right? This is very simple. We all understand demand-based scheduling and demand-based services. But the beauty of this model is that when I make that appointment, my employer, my payer, family members who are nodes in the chain are automatically notified if they have the consent and the pairing with my wallet. So my network of those people that I showed you earlier can be automatically informed without needing to have any kind of a systematic capability. I don't need to buy a new instance of a health information management system or a new practice management system or a new EMR, or need to participate in a new node or a new portal. We are trying to decentralize what has been historically a centralized model of care delivery. And the reason for doing that is over the last 30 years I've been in healthcare, everything we wanted to do to improve care for patients, the answer would always come back to my office saying, how much integration cost do we need? How many years of migration and integration of data do we need to go through? And how many more systems we need to buy? And another data center is probably needed. We are always, IT and our ability to be flexible is always the reason why many of these programs are too short-lived or cannot get off the ground. The notion of a blockchain is that we are eliminating that system-to-system interaction with patient or individual-to-individual interaction through this operating system. Another example is eligibility verification stands on its own 2 feet. Do I really need to call the payer to verify Pradeep's eligibility, or can I get a digitally signed card that is automatically updated so I don't have to check copay, co-insurance, deductible, out-of-pocket maximum for this patient? I know it the day I made the appointment, and I know it the day I'm going to give him service, and I have a cryptological record that eligibility as presented to me on the day of service was this. So there is no dispute. In healthcare, 90% of administrative cost is about reproducing history. I can tell you as a former adjudication system owner, all the time we spent was around, did really things happen the way they presented to me? Did they happen for the right reason? Did they happen within the right entities? Was the entity insured that day? Was the provider in the network that day? And we spend the majority of our time proving that what happened was right. The ledger's job is to take that questioning out of the mix and allow me to do things with a certainty that what happened, who saw, what saw, when saw, is absolutely immutably recorded in the chain. Many other use cases, we're adding medical transportation to the service, where along with the booking an appointment, I can automatically request and receive a subsidized or self-pay transportation, either employer subsidized or payer subsidized or government subsidized transportation capability through the form of a ride sharing. Care continuity post-visit for the physician's ability to stay in touch with me to make sure that I'm taking my prescription, that I'm not seeing any adverse symptoms, that the location of my surgery is not showing any adverse conditions like swelling or anything that brings me back to the hospital. There are ways where the patient-provider interaction can reduce the cost of readmission and the incidence and the frequency of readmissions. Prescription compliance around, are you taking your prescription? What do I do when I miss a dosage? How do I ensure that my dosage record is actually in the hands of the physician when I go see him again, so he sees how much of the antibiotic course I actually took? And what incentives do I have to fill that information, which again then goes back to the care coin as a modes of incentive to comply. As I mentioned, we have launched a 3-wallet system in Arizona: physician wallets, consumer wallets, and client wallet. And these wallets essentially are collectively working together to solve issues like diabetes, cardiovascular disease, so multi-chronic population, pregnancy, and mental health. Those are our 3 big implementations, and many more to come. The last thing that is very exciting is that our client is currently using these wallets to replace all ACH, EFT payments with their own issued currency. They no longer send checks or issue ACH or EFT. What they're doing is paying their providers in the network through their own ACN coin, which is guaranteed value, instantly redeemable coin, which then accrues over time, and the provider has the ability to redeem it at the end, at any point, against a direct bank transfer. So there is a final payment that occurs. But what we have already seen is that the instance of redemption has gone down from daily, weekly, to once or twice a month, thereby reducing their transactional costs, and the physician satisfaction is dramatically up. So with that, if time permits, and actually we're out of time, so I'm going to wrap up. I was hoping to show you a live demo. We do have a booth set up where my team is present to show you what is in production. What I wanted to show you today really was not so much as a bragging, but rather saying healthcare is ready and is able to adopt blockchain if you can demonstrate clear ROI, if you can demonstrate clear stakeholder participation. We have over 50% of physicians who are eligible for the wallet currently using it. So this is not an issue of when will blockchain actually work in healthcare. It is starting to work. And what we are finding is that we started with 5 use cases. We have over 50 different care cards in development or in discussion based on our client needs. So once you have the right framework in place, then the use cases flood in. And that's sort of what we are experiencing. We would love to hear from anybody who is working on a use case or is looking for a partnership with a platform like ours to release your capabilities on the platform. Because once we launch to a larger group of physicians, we expect that these use cases will prove very, very effective, and they're all ROI driven. Again, the company is Solve.Care. We are downstairs. Please come by and see us. We welcome your questions, comments, and feedback. Thank you very much.
Thank you, Pradeep. And now for our final demo,